Hi, my name is Philip Chung. I'm currently a anesthesia resident in the second year at the University of Washington Department of Anesthesiology and Pain Medicine. I'm in the Bonica research track. I received my medical degree from the University of California, San Francisco, or UCSF. I also hold a master's in bioengineering from the joint graduate group between UCSF and also the University of California, Berkeley. My research interest is in natural language processing and in clinical informatics. And some prior research experiences that I've had include spending a year in the middle of my medical school training in order to work at Google Research in their healthcare AI division. And I also previously worked in an academic lab at UCSF that was focused on medical device development and also mobile app development. And then we took these technologies we built and deployed them into clinical research studies in the hospitals and clinics there. Nearly all surgical risk calculators are created from curated database of clinical variables that have been manually extracted from patients' medical records. And I am interested in trying to take a different approach, namely using natural language processing in order to help with the perioperative risk stratification process, and specifically try to leverage the written clinical narratives from physicians which reflect their impressions rather than be focused on specific lab values or problem lists in order to make that prediction. Um, by using unstructured text data with minimal curation from the electronic health record, we may be able to move toward a future where the surgeon may be able to submit a surgery booking, and then we may be able to create some type of perioperative risk stratification automatically. At the University of Washington, in our current process, patients have a discussion with surgeons about their surgical options, and if they decide to proceed to surgery, the surgeon will put together a surgery packet and submit this to schedule the surgery. The surgery packet is put into a queue for which it awaits preoperative evaluation by anesthesia to identify whether or not it is appropriate to proceed straight to surgery or if further risk stratification or testing is needed. The preoperative evaluation process is often a bottleneck because an anesthesiologist needs to review each chart and then decide whether or not to triage to either a clinic visit, a chart review, or a phone or telehealth visit. Ideally, we want to save the clinical visits for patients who are more medically complex or patients for which there are more unknowns about their medical history. After this preoperative evaluation process, a patient will proceed to surgery, and if all goes well, hopefully they have an uncomplicated postoperative recovery period where they can go home happily. However, we all know that this does not happen for all patients, and unfortunately, some of them will have increased hospital stay. They may have some postoperative complications. They may require an ICU admission. I am interested in being able to predict different aspects in this process using natural language processing. We have these physician impressions from multiple specialties encapsulated within the notes in the electronic health record. And it would be great if we can combine this with a description of the surgery to be performed when the surgery is booked, and then input these text representations into a model and then be able to predict what is the best form of triage for this patient, what is their likely surgical risk score. So these are scores like the revised cardiac risk index for cardiac risk for non-cardiac surgery. And also based off of historical data in our electronic health record, what is the likelihood that these patients will have a postoperative complication requiring an increased hospital stay or possibly ICU admission? Here I'll talk about some resources that we have in our anesthesia department. One unique feature is that we have a clinical informatics data core that is called Picasso or PPIQSO. We have staff within this data core to assist with querying data directly out of our electronic health record, which houses clinical data at both the University of Washington Medical Center, as well as Harborview Medical Center and all affiliated clinics. And we have about data going back 10 or so years, and for certain types of data going back even further. In 2020, we brought online a dedicated machine learning server with GPU accelerators and specifically designed the server to be housed within the UW Medicine IT data center. The reason we did this was we were interested in starting to do data science and machine learning work on protected health information or restricted patient data. Um, this needed to be done in a secure environment. If your data is de-identified, we also do have working relationships with Microsoft, Azure, as well as Amazon Web Services. It is possible to utilize these cloud compute resources in order to do data science or machine learning. Also, the University of Washington campus also has a computing cluster where different data science jobs can be run, although these sort of resources outside of UW Medicine are not compatible with protected health information.